work for the NHS. You've had a great idea, you've made it happen, and it's made a big difference to how we can learn from COVID-19 and enter a new normal. Ideas like yours drive improvement and they deserve to be shared. That's what BOB does. Amplifying good ideas like yours across the NHS so as many people as possible can learn from, adapt and implement your idea. The further good ideas are shared by the BOB community who learn from them, the greater improvement we can achieve. You made a change. Share your solution with others. Speak to BOB.
Are live. Just like that. Hello, everyone. Welcome to this session today titled Getting Innovation to Stick in the NHS, Organisations Successfully Locking in Innovations in Light of COVID-19. And I'm here today joined by an esteemed panel of speakers, and I'll introduce each of them now as we go through. So the first speaker we have is Dr. Rachael Grimaldi, and she is an NHS anaesthetist and also founder and CEO of a unique digital communication platform called CardMedic, which is a communication tool improving communication in frontline healthcare. And Rachael has a long-held interest in patient safety, human factors and communication, and has actually been awarded several awards for developing a safer ICU handover. And she's been awarded most notably the international, I'm going to mispronounce this probably, and apologies, Shahid Haran Prize at the College of Anaesthetists. Sorry, I probably completely butchered that, so apologies. And then we also have Davies, who's the managing director of Monticle, which is a consultancy that helps companies to get their technology into the NHS and into the front line, where it makes a real difference to the NHS, to patients and staff alike. And she helps health tech companies build partnerships with the NHS and helps them unlock the funding they need in order to grow and scale. And Catherine's also got a background as a health regulator, so really helps to understand in depth all the different parts of the health system and how they work and what they're trying to achieve, and also the pressures that people are under and the regulatory regime that they operate in. So an interesting background there. And then we're also joined by Dr. Abdullah Albeyatti, who is a doctor with a wide range of skills and interests. Currently, is a general practitioner in Leeds, but also wears several other hats, two of them. So CEO and co-founder of a couple of other companies, MyClinic, which is a free compliant telemedicine platform that allows patients to connect with doctors via video, and also Medical Chain, which is a way to securely store health records and maintain a single version of truth, and that uses blockchain technology. And both of those have had a lot of use during COVID times, and I know we're going to cover off that in this session. As well as that, Abdullah is also an NHS clinical entrepreneur. Then we move on to Mindy Daeschner of Daeschner Consulting. Mindy's background is a vast background in management consultancy, working for some of the world's biggest organizations, having founded several businesses, both startups and within multinational companies. She now acts as a change agent to help support and shape and evolve businesses and solutions to bring value to them. And she works across Europe, Asia, and the US. And Mindy's very keen to see more collaboration and discussion regarding new models of healthcare integration and services. And she has first-hand experience to the complexity of new care models and what they can present, and the opportunity they hold for transforming patient care and improving the healthcare economy. And then I don't know if Paul's on the line right now, but he is going to be joining us shortly. But we've got Paul Charnley, who's the digital lead for Cheshire and Merseyside Health and Care Partners, and also co-chair of NHSX Blueprinting Steering Committee. Until recently, he was the director of IT and information at the digital exemplar Wirral University Teaching Hospital. And as part of that global digital exemplar, the hospital is aimed to be a fully digital hospital by 2020. And he has more than 35 years experience in health informatics, having worked for the National Programme for IT and Northwest and Cheshire and Merseyside Strategic Health Authorities. And last but definitely not least is Iain Fletcher. And Iain is currently Senior Programme Lead for Blueprinting at NHSX. And he's overseen the development of blueprints all the way from concept stage all the way through to having an established methodology for creating and sharing them. And he's going to talk a little bit more about blueprinting later on. But there are now 150 live blueprints written by more than 50 NHS trusts, helping other health organisations digitally transform more quickly and more cost effectively. And before joining the GDE programme and blueprinting in 2017, Iain led the National Communications and Engagement of NHS England's primary care services. So without further ado, I'll just jump into what we're going to be talking about. And really today is about talking about how innovations stick within this time, but also it's looking at the lessons learned during this pandemic, and particularly what changes we think might come out of it on the other side. But before we go into that, I just wanted to quickly flag a couple of other programs that are relevant in this space, and that's the Reset program and also the Beneficial Change Network. Unfortunately, people from both those organisations weren't able to join us today, but being that both these programs really deal very closely with looking at lessons learned throughout this pandemic, and really looking at how to lock them in and ingrain them in the system and change things going forward. So we're going to pop a couple of links about both those programs into the chat here today, so you can have a look at those. But the summary is that the Reset program really is about, this is an NHS Confederation campaign, and it's really there to look at what the system should look like after this pandemic, what that looks like, and how we rebuild services. And really the idea of Reset is to reset the ambitions of what health and care system for the future could look like. And the Beneficial Change Network is similar but different, looking at 16 work streams in NHS England and NHS Improvement, and it's about capturing and sharing those collective learnings across the system. So similar but different, but both have that great intent to try and learn from what's happened, learn from all the changes that have taken place at pace, and see what that could look like in the future. So what we're going to do shortly for everyone watching here is we're going to be posting a poll into the poll section. So to access the poll, you need to actually click on the tab that says polls to be able to answer that. And that should just be underneath or by the side of the speak of the video that you're viewing. So I'll just flag that there. So that should be available, and we'll have a look back at the end of the session at some of the responses there. I'll remind you again midway through to just go there and complete the poll. So what we're going to do then is jump straight to some discussions with our panelists. With everything in mind and what we've just spoken about, I'd like to maybe start off with looking at some experiences of how companies and innovations that have maybe gained traction during COVID times that maybe hadn't beforehand, or maybe had but maybe weren't as visible, and particularly looking at what kind of innovations were most people were most receptive to, and why. Was it staff challenges? Was it dealing with virtual challenges or backlog challenges? And maybe we could look at why certain companies' innovations got stuck and others didn't. And I'm going to aim that question at Catherine Davies, if I will. Catherine, if you wouldn't mind elaborating on some of those.
Okay, gosh, that's a great place to start. Yeah. So I think the context to this is quite important, because there's actually been a huge amount of really interesting innovations this year. But I think if we could just cast our mind back in the mists of time to January 2019, NHS England and Improvement published the long-term plan. And the reason I think this is quite important is because the innovations that we've seen this year didn't sort of fall out of the sky in an unexpected way. They're part of an evolution. And to understand how to get innovation to really take hold in the NHS, you kind of need to understand a little bit about the context. So I thought I'd just touch on that briefly. So the long-term plan was envisaging digitally enabled care going mainstream across the NHS in the next 5 years. So that was very much the direction of travel. And so, for example, the long-term plan talks about digital primary care, digital outpatient services, senior clinicians using digital tools more effectively, when people are ill, being able to be cared for at home, self-management guided by digital tools. So I think it's just important to flag that, because that was already very much the direction of travel within the system. If we think about something like primary care, so at the beginning of this year, the data that I've seen says that 90% of appointments were face-to-face. And now we're seeing 85% of appointments being done remotely. So a massive, massive change already. So a lot of those ambitions in terms of digitization in the long-term plan have really, really been accelerated this year. I think the other thing that's interesting just to flag is that there were a number of major health conditions that were also highlighted in the long-term plan as being of particular importance within the system. And they included cancer, cardiovascular, stroke, diabetes, respiratory disease, and adult mental health. So those were the sort of condition-related priorities for the system. So then if we kind of fast forward to this year, to 2020, I think there were sort of 3 phases of COVID in terms of a system response. So the first phase, everyone was in shock and trying to do the best they could in a very difficult and uncertain situation. So the real priority there was to free up the maximum possible amount of inpatient and critical care capacity in the system. And primary care practitioners were told to triage patients before their appointments, ideally via an online consultation. So that was the first sort of phase, I think, of the system response. And that led to a number of innovations that I'll come back to in a second. The second phase was later in the year, where the system was told to restart non-urgent elective care. And we see a term that started to be used then, referring to locking in beneficial changes. And that then comes up a little bit later as well in communications to the system. So in the second phase, people were told to lock in technology-enabled service delivery options. And then all the meanwhile, obviously, dealing with COVID and the pressures of COVID. And then we get to sort of the third phase, which is about an accelerated return back to near normal levels of non-COVID care while still treating COVID patients. So I think within that kind of context, you see some really interesting innovations start to emerge. So to call out a few of those, I mentioned virtual GP appointments already. There was already a route to market for providers of virtual GP services through the GP IT Futures framework. So we see companies like iPlato, DrLink, Accurix really starting to scale up the provision of online GP appointments. And then we also see the scaling up of virtual outpatient appointments. That had already begun, and some trusts had already started to see patients remotely. But then when NHSX entered into an agreement with Attend Anywhere to grant a license to all NHS trusts to use that technology for 12 months, it then became possible for trusts to access that technology. We've also seen really interesting things happening in diagnostics, and I think that's as a result of a massive backlog that's been caused in part by pausing activity earlier in the year. So we've seen really interesting things, for example, in radiology for the more advanced trusts. We've seen, for instance, the partnerships between radiology providers in the East Midlands and Chiron in relation to breast screening, where they've worked out how to triage people who haven't been seen so that they can prioritise treatment for people who need it most quickly, which I think is really interesting. We've also seen very interesting developments in teledermatology, where cancer pathways have changed so that people can get a diagnosis with the assistance of artificial intelligence in the community, rather than being referred by their GP along a kind of traditional cancer pathway. So very interesting things happening there. Yeah, go ahead. Sorry, there's a lot to say.
There's loads. No, it's fascinating. I was just going to say, actually, and I don't want to be negative on this, but I wonder in terms of some of the key challenges that have been faced, I'm just wondering what they might be, what you've seen those to be.
I mean, I think, so there was a response from lots of innovators to things that were happening across the system. And I think the key challenge is commercializing those initial responses. A lot of innovators have provided their services free of charge, and they now need to work out a funding model so those can really be embedded and implemented going forwards. In a recent paper that NHS E&I published talking about innovation during the pandemic, there's a part at the end when it says funding for these innovations is still to be decided. So what's going to happen?
That's interesting. And if I can open it up, I don't know if there's anyone else on the panel. Okay, let's go to, I believe that's Mindy. I've got a small bit. Yes, Mindy, please go ahead.
Yes, I mean, I think Catherine has given a good summary, and in some ways I was kind of living and breathing some of this, particularly because I was involved in digital triage, both in pilots with 111 and then into the primary care and the delivering actually online consultations with it. And the one thing I would like to say in scale is whenever the NHS comes alongside and really creates a funding mechanism, which is what they did under the dynamic purchasing system for what they called e-consultations, which comes in a variety of buckets of whether that's digital triage or some of the online consultations. It spurred a market in advance of actually the COVID. So it created opportunity and it did spur competition. In some ways, there was lots of competition and things going on also with the NHS app going on that was creating some confusion at the time. But what it did do is it kind of jump-started something in advance and created a funding mechanism for that. That's incredibly important, I think, in leadership with regards to NHS and how they may look at doing some of this moving forward to create the opportunities. COVID was a kickstart for sure, because even though there were some funding mechanisms, actually the time to put a funding mechanism in and actually get the system to begin to procure and actually understand what they're procuring and changing the behaviors, that is the crucial point of difficulty around that, is changing the system. And there's a lag in that. And COVID just forced it. It just forced it overnight. So those are some interesting things. And I think some of the things that Catherine had also said, it created this unique ability around some things. We're doing things digitally within the mental health, within the diabetes, and some of that was just a natural extension of how do you do more with less.
Okay, well, thank you so much. I'm going to move on, but we can pick up some of these themes a little later on. Thank you. We're now going to look at, and this is a question aimed at Iain and Paul, And what we'd like to is really look at how have you seen people utilise knowledge sharing and other mechanisms during this time from a blueprint perspective. We have some slides actually which we're going to post onto the screen. Hopefully they'll come on soon. And then Iain and Paul, if you're able to maybe answer that question with some of the details that you've got there, giving a description of blueprints.
Hi. Been having a few connection problems, so I hope hopefully you can hear me.
Hear and see you
Fine.
loud and clear, Paul.
So yeah, I'm the co-chair of the steering group, and Iain will introduce himself. But as the program leader for blueprinting, we've set out to capture knowledge from a whole range of digital projects over the last 2 or 3 years as part of the Digital Exemplar program.
Oh, we've lost Paul. Iain, are you able to pick up on that?
I will.
Please.
Yes.
Thank
It's going to be an So morning everyone. Iain, I'm Iain Fletcher, the senior program lead for blueprinting at NHSX, and as Paul was saying, I mean, this has been a journey now for about 3 years where we've taken a concept that if initially came out of the Global Digital Exemplar program, where all of the 50 trusts on that program were given some funding from the centre and asked to really capture their best practice. And as part of their learning and kind of them being at the leading edge of some of the technology developments and digital work that was going on, what we wanted to do was really bottle that and use it as a golden thread that we could then share that learning to other parts of the system. And we work with all of those sort of 50 trusts, which range from acute, mental health, ambulance providers, to really sort of capture the essence of the story of what they've done in terms of digital transformation and done well. What we had to do originally was take the concept and turn it into a methodology and something that would be as easy. So what we did, we did some piloting work initially, and then we created a set of tools and templates effectively, which really just told a story. We brought it down to sort of on a really kind of human basis that we all respond really well to stories, don't we? People don't like to sort of see lots of kind of technical data and documents. They want something that tells a story of a journey, and this is what the blueprints capture. So they would talk about how a particular trust or health organisation has got a particular problem and issue. They've done some pre-planning work, they've done the implementation, and they've started then to monitor and look at what the benefits and the outcomes have been. And each of the blueprints tells that very sort of structured story, but thrown into the mix is that we have a range of different artifacts and top tips that people can kind of delve into and see some of the real detail, or they can see, the step-by-step guide for other organisations to come along. And what we're hoping it will do is at least give people a real head start. It will allow them to see how others have learned from their experiences and mistakes they've made along the way, and hopefully avoid those mistakes themselves and save some sort of time and resources in doing that.
That sounds great, Iain. And I just wanted to say, I know that there were a couple that were kind of accelerated through and put up on the platform because of COVID. I don't know if you were able to talk to that at all.
Yeah, so again, just as context for people this morning, so we've got nearly 160 blueprints, and they've been developed pretty much over the space of 2 years. So you can imagine, this is a process that takes a little while because the trust has got to write it, it's got to be quality assured, and then approved by the steering group and uploaded. So it's not something that somebody's going to do in a couple of weeks. However, with COVID, and as Catherine and Mindy have spoken about already, this really kind of accelerated the process. So when we were asked by colleagues at NHS that was going on with video consultations, we worked with Imperial and how they implemented Attend Anywhere. So that was one of the examples. And this was part of Imperial's plan to reduce outpatient appointments by 25% over 4 years. So this wasn't a new initiative in that sense, but obviously what happened was it went into overdrive because of the physical restrictions and the health risks around COVID, and obviously people interacting with health staff what they needed to do was put a lot of this stuff into video consultation, their efforts there instead. And they managed to get around 3,000 staff at the trust set up with Attend Anywhere and able to securely access that system and talk to patients in about 8 days. Which is a pretty major achievement for that trust and for all the people and supporting staff involved in that. And I know from talking to colleagues at Imperial that they certainly feel they've learned a lot in having to do that. Also, strategically, it's taken them along the route they wanted to go along anyway, and it's actually given them an opportunity to do it and obviously do it and embed it more quickly.
That's great. Thank you for that, Iain, and thanks for covering Paul's details there. And I'm just going to keep it moving on, just conscious of time. Interestingly, we've spoken about primary care up top. Catherine mentioned it was mentioned another time, and actually just want to look specifically at that and actually looking at what makes things stick in primary care. And I'm going to go to Abdullah here, and maybe you could talk about your experiences of providing your service during this pandemic. I mean, what have you learned? And maybe if there's some time to talk about beyond the UK, because I know your platforms are offered outside of the UK as well. So maybe talk about what those experiences have looked like outside the UK and if they've been different, and if so, why.
Yeah, so thanks very much for the introduction, Mark, and the other comments in the group. I mean, obviously, COVID has been a big injection, a boost into the arm of health technology. I think as medical professionals or as a health profession, we're quite risk averse, and we always want to see evidence-based medicine or proof of concept before we can actually take on board things. So this can sometimes create a bit of a glacial approach to getting technology embedded into a system. I think in primary care, what's been done well, or will hopefully be done even better in the future, is that there's frameworks coming on board, trying to show companies that this is the conveyor belt system you need to get on if you want to be, if you want to showcase what you've been doing. So, for example, there was one before which is called the dynamic purchasing system, and that was for online providers to get on. That's now evolved in something called the GP/IT Futures Health Desk, and even then, that name is being changed as well. So sometimes it's a challenge for companies to stay on top of what these things are being renamed as or labeled as, but the principle is the same, that there are these frameworks that you want to try to get on board, especially in primary care. And you've got great concepts such as the AHSN, which is all about the academic health science networks. And I think if companies work closely with them, then that's the best way to stay abreast of these changes to get the innovation in primary care.
That sounds great. And what about your experiences from outside the UK? Is there anything there that's been very different from the UK, would you say?
Yes, I think we're very blessed in the UK that we had 4 or 5 telemedicine systems ready to go, Attend Anywheres, the AccuRx's of this world. So when the pandemic hit, we were able to grab this off the shelf, plug this in, use this. There's a little bit of infrastructure and practices. So when I'm working as a GP, for example, I was using my dictaphone as my microphone when I'm talking to patients, even though they can't necessarily see me because I didn't have a webcam. So you're trying to do the best that you could. What we found personally, so with our system called MyClinic, is that we realized there's so many people that have been left behind though. So our biggest users on our platform within the UK were dentists and social workers that didn't necessarily have logins to these other systems, but they also needed to self-isolate or the patients were isolating. And on an international level, we were used in 72 different countries because you realize they're not as privileged as we are in the UK, that you have all these systems which are for free. So we realized there was a lot out there that needed support and needed supplying. And I think we're probably in a similar position to Rachael, and with the great work that she's done, is when COVID came around, you just want to get things out there and you set up this kind of freemium model of just get it out there and get people testing it. And now the challenge is, okay, so what is your baseline product, which is going to be for free? And how are you going to justify and fund all the premium features you're going to add on? So we've had great traction, I'd say, outside more than within the UK.
It's interesting, and actually, yeah, it's a really good point. Actually, I'm wondering actually if we can flip to Rachael actually now, because I think it'd be interesting to hear the kind of the secondary care perspective on some of that, because I know that you launched CardMedic in the midst of all of this, and I know that it's been launched for a little while now, but now things are changing. It's now a new focus, and there's new things that you're learning about, I guess, to get stickiness in the system, and some of those challenges that you might be facing now could be quite interesting, I think, to hear about.
Yeah, thank you. Thanks, Mark. And yeah, very much echo, everybody else's points around the pandemic really being a catalyst for adopting digital innovation in the NHS. And as Catherine was mentioning, this is off the back of the long-term plan. So it's definitely been in the pipeline for a while, but the pandemic has certainly accelerated it. I found when I launched, it was simply in response to a need to be able to communicate, frontline healthcare staff to communicate with patients through PPE was the initial idea that inspired it. But actually, good communication in healthcare is, it's a forever problem. It's been around long before the pandemic, will continue to be around long after the pandemic. And what CardMedic does is bridge a gap in service provision for patients who have visual, hearing, or cognitive impairments, or a language barrier, or PPE. So, as Abdul mentioned, we put it out there as just something for free. I honestly thought, I'm just going to do this to help some friends. I launched it within 72 hours back in April, and we've had 45,000 users in 120 countries and 16,000 app downloads in that time. And then just, touching on kind of Catherine's point and Abdullah's point as well about, now commercializing, it's figuring out, this needs to be free for patients and staff, but it also needs to be sustainable. So it's kind of working through how we make that happen and what the commercial model looks like. And we're working on a licensed subscription model and having different tiers of subscription and then different features within those tiers and functionalities. So I think, for us, the focus is now shifting towards, we're uploading the sign language videos, we're uploading the easy read content, we're expanding upon the functionality and accessibility, we're integrating AI technology into the platform as well, but also working out how to commercialize. And most of our users are 63% are in the UK, 17% are in the US. So we're focusing on UK and US markets at the moment and have lots of connections in those spaces. But it also has potential to expand into other verticals, and we're speaking to the UK Ministry of Defence as well. It's essentially trying to figure out, kind of carving out that path of making this a really cost-effective solution, because it's unique, it's innovative, it's very much needed. But I want it to be a really positive social impact and reduce health inequalities. It can't be a really expensive solution. It has to be able to fit into really neatly into people's budgets. So that's the kind of path we're navigating at the moment, if that helps answer that.
It does. I wonder, does anyone else have a perspective on some of those challenges that Rachel's mentioned there around kind of that stickiness and I guess the change of direction now, so that the great uptake, but then also looking at right now, what next? And maybe either Catherine or Mindy, I don't know, from your perspective of working with other companies.
Yeah, I mean, I wanted to loop back to this point about funding, because I think it's so important that we have to fund these innovations if we want to see innovation in the system. So there are lots of organisations that are in the same situation as you, Rachael, where they've demonstrated that they're able to add value to the system. They can help patients, they can help staff, but they'll just run out of runway if we can't get funding into the system. So I think really there's an opportunity for everybody in the health tech community to come together and have a conversation with the centre about how we're going to fund this change. Because if everybody needs to have bilateral conversations with individual NHS organisations around the system, it just won't happen. And we talk about locking in beneficial change. If we really want it to lock in, we've got to make it easier for people to spread innovation by helping them understand how people achieved it, who have done it successfully. And we really need to get the funding into the system at scale so that innovators can really embed their technology.
For me, that feels like music to my ears, because I've received Innovate UK funding. I've had 2 grants from Innovate UK, and I'm actively fundraising at the moment with investors. But this is, communication in healthcare, as you said, is it's everywhere, and this is a solution that impacts primary care, secondary care, tertiary care, pre-hospital care, pharmacies, dentists. It can reach absolutely everywhere. So to have that kind of top level approach of how do we get this funded, how do we get this widely adopted, it's really hard to penetrate that space from a kind of innovator's point of view. Sorry, Mindy, I'll let you chat.
Mindy, that's great.
Yeah, I think probably this is a very interesting conversation for whoever's out there listening to us talk. I think commercialization is often considered a bad word or a naughty word within the NHS, just because it's not meant to be offensive. It's just kind of fact. But in actuality, a lot of the NHS is actually privatized by the nature of the organizations that support it, and even primary care to a certain degree. So it's important to understand the basics of some of these things. But I do think that the commercialization aspect of companies is very, very important, and how that's talked about. Oftentimes that's sponsored directly by VCs, and if you reach a certain scale, private equity. But there is a known fact here in the UK that a lot of VCs in early stage do not like to fund organizations that their main supplier is the NHS, because of the time it takes, the effort to get in, and all of that. And I think we are now at a state, particularly with COVID, it's shown that, and where we're going, that there is a direct equation to health equals wealth. The healthier we are, the more productive we are, the more as a nation we make. And we're entering probably a huge recessionary period where we know there's going to be strains on funding within the NHS. But sometimes the only way out of these constraints is through innovation. So I think there needs to be some type of focus around that, and it needs to be important. But I do think there's a lot of companies out there struggling with commercialization that don't really necessarily have a specific problem and an ROI that they're focusing on. And I do think there's two bridges to gap.
Yeah. Absolutely. I just wanted to flag at this point as well to say that actually Rachael has actually written up a couple of impact stories on Bob as well. I think the link has been posted in the chat as well. So if you work in the NHS, sign up and check out those stories where Rachael and others are sharing their experiences of actually using the CardMedic solution. But I just wanted to go back to Mindy again and to elaborate on some of the things you were saying, because the other thing is Mindy created a great report, which I believe the link is in the chat as well, so you can all go and read that. And I think from there, I think it'd be interesting to look at, because I know you looked at some of these things as to why innovation stick, what it was. And you mentioned that it requires an attitudinal change to get that. And people are changing. They're changing the way they embrace innovation. Catherine mentioned that. I thought every speaker actually mentioned that. And there's more prevalence of it in everyday life. And I was just wondering if you might be able to elaborate more on some of the kind of the key bits that you got from that report that might be interesting. Thank you.
Thanks. I would be delighted to. To a certain degree, the report was spawned from a lot of the challenges I faced, when I was very much involved in working with the NHS. I've been an entrepreneur, and a lot of that is almost predominantly all been in health technology. But it was traditionally within the private sector, because they make decisions faster and their commerciality is so acute. Whereas sometimes with the NHS, the people that you're actually procuring feel a little bit disconnected from the commercial realities, because that's often center funded around that. And really, I did it to get an understanding. I recognized that COVID was such an enormous change within the NHS, all healthcare, and every individual. And what I wanted to do is get a pulse on it. So I did a report that covered about 150 senior people within healthcare, both from the NHS, also private and health tech. So I didn't want to narrow it to one, to really get an understanding of what they see as some of the challenges and the big areas within that. And I think what came out loud and clear was that COVID has made an attitudinal change across the board. And the attitudinal change is healthcare is a laggard in using technology, almost of every industry. Maybe not education, maybe not law, maybe they're on par, but it is a laggard. And what COVID has forced, because of the virtualization and the need to have more flexible workforce, changes to happen quickly. People didn't have a choice; they had to change. And what the system saw is, actually, we can change. We can change quickly. And I think there was also unconstrained, the ability to make maybe decisions a bit more locally and not so much pressure from the top, created interesting dynamics, which I think a lot of people embraced. Perhaps maybe not the speed that they had to do it, and there's learning come out of it. But attitudinally, I think there's been a shift there. Whereas time, not my responsibility, don't have the right skill sets. It's just like, we got to do it. Necessity is the mother of all inventions. When you got to do it, you can do it. And what kind of came out of that, I think, is really some really interesting things. And I think we're seeing some stuff that isn't health tech, but I also think it's really interesting things also coming from the center. So there needs to be center and a lot of regional things. But kind of the big things coming out was the really need for data and real-time data. The NHS lacks that. And a lot of the decision making, particularly around, COVID and capacity, showed a lot of that, and the need to change and have a better handle on that. So I think we're going to see data and how we make decisions around data evolve over the next 5 years rapidly. The other side was the virtualization and the diagnostics. I mean, one thing I will say, and this is a credit, the NHS has just recently announced a deal with Grail, which is around this blood testing for cancers. That has the potential to reshape in such an enormous way and be preventative. So it's not just about digital health, it's about lots of different technologies around that. But this is really what we're seeing is a real shift to sustainability, prevention, putting more things in place. It's early steps and it's early stages. But COVID has rapidly fostered that. Yeah,
absolutely. Thank you very much, Mindy. Sorry to cut you off there at the end. I just wanted to touch on a couple of things. The poll results. Also, we've had a couple of questions come through, which I want to try and get to before the end of our session. So the poll results. Unfortunately, I can't show you the results. I'll just tell you. So we asked the question to the audience: what do you see as COVID-19's biggest healthcare legacy? And so the response is that the biggest response we had was actually changed working practices forever. Second to that was accelerated use of virtual care. Then we had slowed down adoption of digital health was there. And then the last one was jump-started digital health revolution. And actually one of them didn't actually get a response at all, which was the point around eased use of digital health apps and mindfulness. So that's interesting. And I don't know whether or not there's any very quick reflections on that. Any surprises there from anyone on the panel want to comment on?
I think from a primary care perspective, there are a lot of positives to take from the remote working, which we've been doing. There's a lot of benefits we've had, both from the patient and the clinician's perspective, of not needing the patient to drive 40 minutes to come to an appointment, try to find parking, struggling to find parking, wait in the waiting room for 25 minutes, speak to the doctor for 5 minutes and out the door. So I think there's lots of things that we are doing. I don't think we're doing it in an efficient way yet, because patients are still receiving random phone calls when they're not expecting it. And I think we need to get a lot better at allocating times to patients, creating a kind of virtual waiting room, a virtual queue where you'll get to somebody when you can. But I think it's definitely the early steps there, and we need to just do things a lot better, which tie in logistically. I think one of the challenges we have, just to end on this point, the technology always gets blamed, and it's not the technology's fault. It's the logistics of how you're deploying that technology, and that's what we need to work on.
Very good point. Very good point. And I'm just going to quickly flip. We've got 3 questions here. Let's see how many we can get through. So this is a question here from Fiona Willis. Thank you. How does the panel think they'll be able to encourage older users to engage with new technologies? Who wants to take a stab at that one then? Is that Mindy? Yes, Mindy, go ahead.
I'll do it, because there's some evidence coming out where I was before that actually people often skew this to millennials. I'm firmly in the middle-aged category, but I think but above. But what we did see on a lot of the virtualization, digital triage, and there's a huge concern that the elderly will be left behind. And I think within healthcare, there's a multi-channel approach. There's not a one-size-fits-all, for sure. But it's surprising the amount of older and elderly people that pick these tools up. Yeah, I mean, they're already using them to communicate with their family because of the distance and not being able to see in people in care homes and all of that. So I think there is a little bit of a misnomer that the elderly won't and can't use these type of tools. And what we're also seeing, and I think this is the fundamental thing, and I say this again as part of Daeschner Consulting and almost everything that I like to get involved in with regards to digital tech or innovation, we are in the age of the consumer. It has to be convenient. It has to be easy to use, and it needs to be engaging and fulfill that. And healthcare has traditionally been set up for clinicians and consultants in buildings. So this is a fundamental change, which I would almost call a rupture, that's going to be happening, and it's going to be painful. But over the next 5 to 10 years, we will see a complete difference. And I also think we'll see how money follows a patient differently, which will radically change some of the processes. And I'm sure Iain's probably involved in some of that and has got a lot to talk about.
I'll let Iain go. We've got just a flag for everyone that's listening as well. We are due to finish at 12:45. I've been told that we can go over by a couple of minutes. If speakers, if you're okay with that, we can do that. And we can answer maybe a couple of questions.
Apology, sorry. Now, I was just going to follow up Mindy's point and say again, I think that the view about older people not connecting or not engaging in technology isn't always being borne out. And I think some of the work that we during COVID, and they introduced an app where, for obvious reasons, they didn't want lots of patients going into healthcare settings, but it was actually better to keep them at home and keep an eye on their condition at regular intervals. And the early results from that again have been pretty promising. And I suppose what we have to consider is obviously that's working for a particular, we'll kind of keep reviewing that, but it seems to be working, that approach. I suppose what we always have to be careful about is still thinking about the digitally excluded and not just lumping in, not going for kind of generic groups of people, like talking about the middle-aged or the elderly or younger people. Obviously, you know, we need to be more sophisticated about that, don't we? And there's a greater degree of segmentation needed. I think sometimes we do tend to talk in generic groups, and I think that, you know, we're all guilty of doing that. And actually, people's needs are quite complex and multifaceted.
Absolutely. Thank you both. I think maybe let's try one more question, because there's two. Actually, we've both up and they're related. So we've got one question, which is funding of digital innovation reimbursement is absolutely key. Which organisation within the NHS is responsible for this? And then a similar but slightly different, but it's a funding related question, is do you think there's a possibility for NHS or CCGs to reduce or relax regulations in the future, so to attract investors for VCs for funding? So similar but not quite different. Let's go with the first one, the funding of digital innovation question. Any organisations that you would go to and say, yes, absolutely, that's the one to go to for this? Catherine.
Yeah. So just quickly, so unfortunately, lots of people are responsible and then no one ends up being responsible. That is part of the problem. I think NHS is really trying to get this to work better. So I think having more conversations can be very helpful, so we all make sure that everybody's on the same page. And I think this relates to the second question as well. So we're spending public money, so we need to make sure that we're allocating public money in the most sensible way. But it is such a shame if VCs and other investors see on someone's business case that they want to work with the NHS and then they just don't fund them. That's not good for anybody. So I think we need to have more conversations with investors and VCs and NHSX to actually start this dialogue to say, this is what we need to see to be able to invest. It might be priorities, it might be funding going to particular bits of the system. And if we see that, we'll be willing to invest. And then also innovators then wanting to go with a direction of travel and innovate in the areas that have been articulated as priorities. And I think if we could do that a bit better, it might help with some of this reimbursement challenge.
Absolutely. Before we look to wrap, does anyone else have any other comments on those points around funding?
Hi. Yeah, sorry. Just to add on to Catherine's point there, having spent the last few months actively fundraising and speaking to investors and VCs, and I've got a pitching event tonight actually. So in terms of how they view the NHS, very much echoing everybody's comments about NHS is slow to innovate and slow to uptake, and they don't see it as a kind of viable commercial stream, revenue stream. But where which is really disappointing, obviously, but where they do see it is, they understand that as innovators, if you manage to innovate in the NHS and you do get uptake, albeit slower, it's a blue badge of honour. As then you can kind of go overseas with your blue badge of honour, and that helps. The other kind of frustrating part is they want letters of intent, but NHS trusts don't like giving letters of intent. So you can say, I've got these things in the pipeline and trusts I've spoken to, and they want to do pilots, or they want to pay for. I have 2 trusts, for example, who want to pay for a license subscription model in their new financial year because they're merging, but they don't want to supply a letter of intent. So it's really tricky. You kind of get caught in the middle. So what I'm doing has huge amount of promise and potential, and but it's difficult being pre-revenue and speaking to investors because I'm kind of stuck between angels and VCs needing a lot of upfront investment to invest in patients and the sign language, but and to kind of get out there, but actually long term, the return on investment is potentially huge. So you're sort of stuck in that no man's land, and until I start maybe getting traction through actual sales, it's a tricky space to be. So yeah, it would be great if you could go and knock on one door on the NHS and say, look at this idea, everyone's using it in the NHS now. We just need some kind of uptake and funding for it, but it just hasn't, it doesn't work like that.
I was going to say one of the things that the NHS probably could do better is to stop changing the goalposts, because for innovators like us or entrepreneurs or startups, every time they say, okay, now you need this ISO certificate, now you need to get this clinical safety officer on board, now you need to jump through this hoop, that's 10 grand, 10 grand, 5 grand, 10 grand. And that money you spent, the first 20K, has already gone in the bin because it's irrelevant anymore, those standards you were aiming for. So I think one thing is obviously trying to get money in one way for us to use and to build, but the other way is we've got to stop taking the money at the other end and try to stop changing the goalposts and say, this is the standard and this is what you need to meet.
Well, listen, I think I'm sorry, Mindy, I'm going to have to draw it to a close now. I think my lessons learned was 45 minutes was never enough for this kind of conversation. I mean, that's for sure. And the one thing I would say, first of all, thank you very much to all our speakers for sharing their experiences. And you can find them all. They're all online, LinkedIn, and so on. If you wanted to connect with them, like I said, the CardMedic story is on BOB.health. If you'd like to have another look at that as well, to read that story. And I guess just very quickly, just wrapping up, interestingly, the key things we've heard, and I didn't maybe expect it to come out as much, was a conversation around funding models and procurement was definitely one of the things. If we're looking back at what locks in innovation during this time. The other thing was making sure that these lessons learned really are lessons learned and they are actually communicated and shared and actually used during this time. And the third thing I would say is, let's not get too fixated around the tech. It's not just tech that's innovating during this time. There's many other things that could be very useful that we could learn from during this process. I mean, there's probably thousands of other things I could say, but those are the 3 quick things that I've captured. There's been many more. So I'd like to say thank you very much to the panel for joining and contributing to this. And and we'll leave it there. Thank you very much all.
Thank you.